Good morning, everyone. Welcome to week 2 of Cardiovascular Physiology. So the first thing that I'd like you to have a think about, can you define afterload? SEAC, would you like to have a go at that for us, please?
So my definition of afterload is the impedance to left ventricular ejection.
I agree with you, SEAC. I think it's all about the load that the ventricle has to exert its force against. And another way of putting that is the sum of all of the forces that oppose left ventricular ejection, or the aortic pressure against which the left ventricle ejects blood from the heart into the arterial circulation. I think I prefer definitions 1 or 2, and the reason for that I think is just in terms of when we come on to describe the factors that affect afterload. So once again, I'll give you all 30 seconds to have a go at jotting down the factors that affect afterload. Tom, how would you structure your answer to factors affecting afterload, or broadly speaking, how would you break up your answer?
I'm thinking of it in terms of wall tension. There's things that increase the pressure which the heart's pumping against. So that's things like outflow obstruction, valvular disease,
yep.
Increased aortic pressure, so decreased aortic compliance.
Yep.
And then there's things that reduce the transmural pressure, so that's things like increased intrathoracic pressure, or PEEP.
Look, I think what you haven't sort of verbalised, but exactly the way that you've divided it up is you've talked about factors internal to the heart, then you've talked about factors sort of in the left ventricular outflow tract, and then you've talked about factors external to the heart. So I actually quite like the way that you divided that up. Let's talk about the factors internal to the heart first. So really that comes down to Laplace's law, which says that the tension in the left ventricular wall fibres is proportional to left ventricular pressure times left ventricular volume divided by wall thickness. So, for example, if we have a dilated left ventricle, as in a failing or a ventricle with cardiac failure, that ventricle will have higher afterload. However, a ventricle that is thicker with left ventricular hypertrophy will have a higher denominator and therefore a lower afterload. So when we consider left ventricular hypertrophy, we need to consider whether it's an eccentric hypertrophy or a concentric hypertrophy. Typically, it's concentric hypertrophy that you would see in a disease state like aortic stenosis, where you don't have a dilated ventricle, but it's just thick. It's that really thick donut left ventricle that you see on echo. And that compensation that ventricle makes is in an attempt to reduce the afterload that has been increased by the outflow tract obstruction. So concentric hypertrophy, thick ventricle, increased wall thickness, but without an increase in left ventricular volume. So only the denominator increases, therefore the afterload is lower. An eccentric hypertrophy is where there's left ventricular hypertrophy with LV dilation, so the effect on afterload is roughly neutral. Whereas a dilated ventricle, an increase in volume and a thin wall will have an increase in afterload. So that's factors internal to the heart and can be explained by Laplace's law. As Tom said, there are factors that affect the left ventricular outflow tract. And the most obvious one and the most common one really is aortic stenosis. But there are other congenital causes of LV obstruction, LVOT obstruction, and also acquired causes in things like HOCM or SAM, where you get sort of the left ventricle primarily in that septum. You get a septal bulge in the left ventricle that bulges into the left ventricular outflow tract, brings the mitral valve leaflet down and causes an obstruction to outflow. The one outflow tract disease state that people never remember when we're talking about afterload, although it's not in the outflow tract itself, is significant mitral regurgitation that in fact decreases afterload. It's not in the forward flow outflow tract, but it is a outflow for blood from the left ventricle. And in fact, what it is a low pressure backwards valve, if you like. And we often find in patients who've got significant mitral regurgitation, when you fix that mitral valve, because you effectively increase the afterload in that patient, because you take away that low pressure backwards flow, you can uncover a ventricle that's not very happy. So some of you in ICU would have looked after patients who've had mitral valve repair or mitral valve replacement. And sometimes they struggle a bit for a few days, and it's because that left ventricle that's used to having the backwards, the low pressure backwards outlet doesn't have that anymore. So effectively that ventricle's afterload is significantly increased, and we can uncover mischief. And then we go on to the factors that are external to the heart. As Tom mentioned, intrathoracic pressure does change that transmural pressure between the heart and the thoracic cage. And negative intrathoracic pressure results in an increased afterload, and a positive intrathoracic pressure results in a decreased afterload. So that is the explanation as to why PEEP or other non-invasive ventilation can in fact assist the failing left ventricle because it results in an effective decrease in afterload. The aortic pressure at which the left ventricle needs to pump also affects afterload. And I think SEAC was the word that you used, compliance or impedance?
Impedance was the one I thought.
Yeah. So, you know, we use systemic vascular resistance that we did spend quite a bit of time last week talking about as a surrogate measure for impedance in the arterial tree. And therefore things that either cause vasodilation or vasoconstriction will alter your afterload, and obviously hypertension and aging will have an impact on SVR as well. The other, I guess, disease state, or it's not a disease state, but I guess intervention that affects afterload that people often forget to talk about is an intra-aortic balloon pump. And the whole premise really of the intra-aortic balloon pump is that it decreases afterload. I'd like you all just to have a look at that multiple choice question. Give you 20 seconds to do that. Simon, do you want to have a go at that one for us?
So I would go for C in that case.
So you think that impedance is the opposition to pulsatile flow. You think that impedance and resistance can be used interchangeably. And you think that resistance is the opposition to non-pulsatile flow. But impedance is not the combination of compliance and resistance. Is that what I take from your answer?
I'll say yes, very importantly.
So look, my intention with this was that the correct answer and the false statement there in fact is B. And really perhaps it is a little bit simplistic, but impedance is the opposition to, is the term that we use for opposition to pulsatile flow, whereas resistance is the opposition to non-pulsatile flow. And therefore, you know, B, you know, strictly speaking, cannot be used interchangeably. But impedance is a combination of both compliance and resistance. Okay, what is systemic vascular resistance and how is it calculated? So look, I guess the definition that I have for systemic vascular resistance is the sum of resistances to that flow of blood through all of the vascular beds in the systemic circulation. What we talked about last week was the derivation of Ohm's law. That is, the systemic vascular resistance is the pressure difference divided by the cardiac output. So I've just taken us through another calculation there. If we said that the difference between the arterial side and the venous side is the difference between the mean arterial pressure and the right atrial pressure, let's call that difference 60, divided by the cardiac output of typical values of 5 litres per minute. That calculation gives us an answer in Wood's units, and in order to go from Wood's units to dynes per second per centimetre to the -5, we need to multiply by 80. And as we said last week, you know, a value roughly 1,000 we would consider to be a normal systemic vascular resistance. Values significantly less than 1,000, the patient would be thought to be vasodilated, and more than 1,000 would be quite vasoconstricted. Okay, a bit of revision from last week. As quickly as possible, I want you to draw a nice big pressure volume loop for the left ventricle. And as soon as you finish drawing that, I'd like you to have a go at drawing in a second loop for a patient with a higher afterload. So hopefully you have drawn something a little bit like this. Remember we talked about last week, if you're asked in a Viva setting or even for a short answer question, if you're asked to change only one factor, make sure that the others are identical. So that is the preload and the contractility are identical, and it often is easier to draw those in first. So the preload is the same for the second loop. The contractility is the same for the second loop, but the afterload is different. So the slope of the afterload line is higher. Therefore, we'll draw this second loop to be narrower and slightly taller to meet that new afterload line. Dom, do you want to have a go at what you would define as how you would define blood pressure?
What we commonly refer to as blood pressure is often systolic blood pressure, mean arterial pressure, and diastolic blood pressure.
Annie, how do you calculate mean arterial pressure?
I think clinically you just you measure the systolic and diastolic, so 1/3 of systolic plus 2/3 of diastolic.
I think that's the same as 1/3 of the pulse pressure plus
diastolic pressure, yeah.
Which is the way that I would calculate it. Yes, you can use the derivation of Ohm's law, and you know, if you know the cardiac output and the systemic vascular resistance, we can calculate mean arterial pressure that way. If you had a pressure time trace,
area under the curve.
Excellent, very good, very good. And in terms of a definition for blood pressure, if you're asked for a definition, I would use one of these two. So blood pressure is the force exerted by blood against any unit area of vessel wall. And when we're talking about measuring pressure, that's the force required to elevate a column of blood against gravity to that certain number of millimeters of mercury. Annie, since you're on a roll, what is pulse pressure?
The pulse pressure is the difference in pressure between systolic and diastolic blood pressure.
And what would cause an increase in pulse pressure?
Stiff vessels, so you don't get that elastic sort of potential energy stored in the vessel as well to buffer the changes, so that's less able to, I guess, absorb the, I don't know, this sort of how I think about it. So stiff vessels.
Yeah, and that's what we see in practice, isn't it? We see elderly patients who've got, you know, reduced arterial compliance, often have quite a high pulse pressure. High stroke volume often results in quite a large pulse pressure. And then inspiration, we get an increase in pulse pressure on inspiration as opposed to on expiration. So I've got the timer on. You've got 3 minutes in which to do this short answer question. So what I would have hoped you would have got in that 3 minutes is 4 main headings of arterial baroreceptors, a chemoreceptor response, a little bit of a discussion about some hormones, and the CNS ischemic response. So that would be just a sort of a sketch out I'll talk a little bit more about arterial baroreceptors, and I'm sure you've all got quite a bit of detail about that, and that comes on the next slide. But in terms of the chemoreceptor response, that will result in an increase in sympathetic, and it will result in an increase in sympathetic activity, and that is triggered by either a decreased oxygen or increased carbon dioxide that results from the poor blood flow from a reduction in mean arterial pressure stimulating chemoreceptors. The hormone response, particularly with adrenaline, with the catecholamines, can result in acute changes in blood pressure. ANP is released by the atrium in response to an atrial stretch, and that's a potent vasodilator, as well as causing diuresis, although the diuresis won't be an acute change. And then the CNS ischemic response is really a very powerful sympathetic response that responds to a direct response of a neuronal response to ischemia. I'm sure you've all got quite a bit of detail about the arterial baroreceptors, and the conversation I was having yesterday with the candidates that are sitting in August is that it's a constant challenge when you're doing short answer questions to know how much detail to go into. You need to make sure when you're doing a short answer question that you've got the breadth of the question right, first of all, before you go too far down a hole with detail. Clearly, in this sort of question, there needs to be a degree of detail about the arterial baroreceptors. They're certainly a very important part of the response to acute moment-to-moment changes in blood pressure. But if you've spent, a page and a half on detail on the arterial baroreceptors and you've not talked at all about the chemoreceptor response, the hormonal response, the CNS ischemic response, then your total mark out of 10 will probably be, a total of, say, 6. So even if you've got every single possible detail for baroreceptors, your overall mark will be limited. So I think the take home with how much detail is that once you've got the breadth right and you've got all of the important points in the question down, then by all means go into detail as your time allows, but make sure that you've got the sketch out right first. So as you know, and you will have just sort of written on your pages, no doubt, arterial baroreceptor response, they're the receptors primarily in the carotid sinus and the aortic arch. They really don't start firing until the blood pressure gets greater than 50, a mean of greater than 50 to 60, fire maximally at 200 millimeters of mercury in response to wall stretch. At a normal blood pressure, then a small change in pressure results in a greater relative change in baroreceptor firing than at extremes of pressure. And firing of the baroreceptors results in an inhibition of sympathetic activity and stimulation of parasympathetic activity. And then I've just got the afferent and efferent pathways listed there. And as you know, the primary purpose of that arterial baroreceptor response is to reduce the constant fluctuation that would occur in our arterial pressure if we didn't have that baroreceptor response. And it's a crucial response when we move from lying to standing. Far less important for acute blood pressure changes, so I just put this in here for completeness to sort of finish off the discussion, is the low pressure baroreceptors, or otherwise known as the cardiopulmonary receptors that are present in the atria and pulmonary veins. And their aim is more to limit the impact of that change in blood pressure on blood volume. In response to being stimulated, there is an increased sympathetic activity and an increase in heart rate. with a decrease in, and that Bainbridge reflex increases the heart rate in response to an increase in blood volume in order to prevent damming of blood in the veins and in the atria and within the pulmonary circulation. So sort of wanting to move blood through the heart. The rest of the low pressure baroreceptor response is an increase in urine production that's facilitated by a decrease in renal sympathetic activity, inhibition of ADH secretion, angiotensin II, aldosterone to prevent water reabsorption and sodium reabsorption, and again that release of ANP causing vasodilation and diuresis. So the overall effect of stimulation of the low pressure baroreceptors is an increase in heart rate and an increase in urine production, but less of an acute response. So what we've said so far is that if you have an increase in blood pressure, then you'll get an increased firing of our arterial baroreceptors, and that results in decreased sympathetic activity, increased parasympathetic activity, and overall a decrease in heart rate. We've also said that if we get an increase in blood pressure due to an increase in blood volume, then we'll get firing of the low pressure baroreceptors. And as we said, the Bainbridge reflex is an increase in heart rate to prevent damming of blood in the veins, atria, and the pulmonary circulation, and to keep blood moving through the heart. We've also said, and we know that if you have an increase in atrial stretch, then we get a direct effect on the SA node itself, and that results in an increased heart rate. And we know that we've got the Bezold-Jarisch reflex at play too, which tells us that if we're severely hypovolemic, then and in order to prevent sort of a vigorous contraction of an empty ventricle, then this reflex is stimulated, and that causes a reflex bradycardia and vasodilation. So the question is, who wins out? We've got some factors there that increase heart rate and some factors there that decrease heart rate. The answer to the question as to who wins depends on the duration of the change. Is this a quick change or is this a slow change? And what is the volume of blood in the system at the time of that change? And what we can basically say, and this is a little bit of a simplistic view, but what we can basically say is that when the blood volume is greater than normal for a normal blood pressure, so we're not talking about states of shock, but we're talking about a patient who has a relatively normal blood pressure. When their blood volume is increased above normal, then the Bainbridge effect will be predominant. That is, we get an increase in heart rate. But for a normal blood pressure, when our blood volume is lower than normal, then the arterial baroreceptor effect will be predominant. That is a decrease in heart rate. However, in states of shock, then the arterial baroreceptor response will override all reflexes and we'll get an increase in sympathetic activity. What I'd like you to do is jot down on your notepads the effect of sympathetic stimulation on the heart, including the ionic basis. The main points that hopefully you've jotted down, if we answer this according to the type of action potential, and first of all we look at the slow type action potential in the SA node, then sympathetic stimulation increases the slope of that pacemaker pre-potential by increasing the inward sodium and calcium currents such that the inward current exceeds the outward potassium current. That increase in slope will result in an increase in heart rate. and the slow type action potential in the AV node will also get an increased slope and amplitude of the AV node action potential due to an increase in calcium permeability in the N region of the AV node. When we look at the impact on the fast type action potential in atrial and ventricular myocytes, then sympathetic activity will result in an increase in calcium influx into the cell, as well as an increased sensitivity of those contractile elements to calcium, and an increase in calcium reuptake into the sarcoplasmic reticulum. So sympathetic activity has an impact both on systole and the active relaxation that occurs in diastole. So overall impact is of increased heart rate, increased contractility, and improved lusitropy or improved relaxation. So you could have guessed what the next question is, and that is the effect of parasympathetic stimulation on the heart, including the ionic basis. So once again, if we examine the impact on the SA node, parasympathetic stimulation will result in an increase in potassium permeability and an increase in the outward potassium current, thus a decrease in the slope of that pacemaker prepotential. In the AV node, again, an increase in potassium permeability will result in slowed AV nodal conduction. And again, that's primarily happening in that N region of the AV node. The fast type action potential in atrial and ventricular myocytes is impacted due to inhibition of adenyl cyclase, which increases cyclic AMP and results in an overall decrease in calcium conductance. So the overall impact on the slow and fast type action potentials from parasympathetic stimulation is a decrease in heart rate and decrease in contractility. Can you tell me the difference? And a diagram would be a good way to demonstrate this. The difference in the pulse contours between the radial artery and the aorta. Maggie, I might get you to either share your screen with us, or happy for you just to talk through it.
So I drew on the y-axis pressure, on the x-axis time.
Yep.
And then the two diagrams, so my aortic one starts a bit sooner, has a smaller peak, and has the dicritic notch closer to the systolic peak, compared to the radial one, which has a higher systolic, a lower diastolic, is a bit delayed, and the dicritic notch is further away.
Good.
And then in terms of the reasons for that, so I said that the delay in the peak is the time required for the pulse pressure wave to travel from the aorta to the radius, and I think it's not a very big delay. It's only like 0.6 seconds or something like that. The increased systolic peak is, I think, due to the summation or the addition of the reflected waves that are coming from the peripheral vasculature. So they kind of like add to the peak pressure there to cause an increased amplitude. The dicritic notch at the radial artery is, at the aorta, it's due to the sudden closure of the aortic valve, so it's quite defined and close to the systolic peak, whereas the radial dicritic notch is due to maybe that part's due to the reflected waves coming back from the peripheral vasculature.
Yep. Yep.
The diastolic pressure, I think, is decreased in the radial pressure wave compared to the aortic, and I think that's due to decreasing compliance of the vasculature. So you have decreased Wynn-Kessel effect, so decreased storage of the potential energy during the systole.
You've got a fabulous understanding of that. Thanks, Maggie, and you've explained that really well. I think the way that if I was doing this as a short answer question, sort of following on from Dom's question, I would pick one of them and explain how one is different to the other. And that's, I guess, what I've done in this slide here. But they're all the things that Maggie's just sort of taken us through. So I've just sort of chosen to say that all of the ways that the radial one is different to the aortic, which is probably not a bad technique for a short answer question. These changes are more marked in young people, with less of a change seen in elderly people because of a less compliant aorta. Yeah, I don't really have a lot to add on top of all of the detail that Maggie has taken us through. Thank you. Okay, I would like you all to fill in this table with the relative percentage of cardiac output for each of the circulations that are listed and what that equates to in terms of mils per minute. So of those numbers there, the hepatic circulation receives the largest percentage of cardiac output in the order of about 30%. We're looking at a cardiac output of roughly 5 litres a minute. It's about 1.5 litres a minute. Alex, why is it that the kidneys that are only about 0.5% of your body weight, why do they receive so much blood flow?
My understanding is that essentially it's due to their function themselves, in the sense that they remove waste products and they are heavily involved in concentrating our urine and maintaining our blood volume. So they're obviously relatively important. So they, like all the systems that have sort of high blood flows but kind of small size, it's due to their actual function. Yeah,
that's right. So look, the amount of blood flow that the kidneys receive is about 10 times what they actually need in order that would be required purely to deliver oxygen and nutrients. That's right. And Alex, skin blood flow that I have there of 400 mils per minute, what would be the range in blood flows that we could reasonably expect to skin if we think on the one hand of a very cold vasoconstricted system, and on the other hand, extreme heat? What would be the sort of the minimal blood flow that you might see to skin, and then the maximum?
I imagine it could be, and this is just a guess, but I imagine it could be anywhere between, anywhere down to like 2% of cardiac output all the way up to sort of 15% of cardiac output. It's probably a bit too much, but maybe to 10.
No, look, the lower end, you're not far off. So I've got a lower limit of about 50 mils per minute. So what's that? Yep. That's about 1, I think. Yeah. And up to a high of up to 3 litres a minute. So
wow, okay.
Enormous ability to, now that would be in the setting of a much higher cardiac output. But yeah, so skin blood flow can change anywhere between 50 mils per minute in cases of extreme cold, up to 3 litres a minute in cases of extreme heat and vasodilation.
Can I just add something, Louise, just back on that slide? And this is just for everyone who's sitting the exam. Someone told me a really good mnemonic for this. If you write, so having sex brings kids months later, that puts this in order of volume, and it's pretty much like 5%, 10%, 15%, 20, 25, 30. So you can, it's the easy way to remember. So that's how I've written it down here. It's just in order of volume based on that. So if anyone needs the mnemonic, I can send it to them.
What's the brings that?
So H is heart, and then, or coronary. S is skin, B is brain, K is kidneys, M is muscle, L is liver.
I like it. Okay, here's another little one for you guys to fill in. What I'd like you to do in this table, obviously the top bit of the table hopefully is fairly self-explanatory. What's the total blood volume in terms of mils per kilogram? and how does that differ in a newborn. For this part here, I want you to give me the blood volume in normal situations, and then for the situation of the veins, so the first box and the bottom box, give me how that changes when you are supine. And then just give me a one-liner on the function of those particular vessels. For example, for capillaries, I would put that they're the exchange vessels. Roughly, as we said last week, 70 mils per kilo, which is higher in the newborn. The veins will have the vast majority of blood volume. Again, we talked about that last week when we were talking about the vascular function curves, and that will decrease slightly when you're supine, and the function of the veins, other than being a very highly compliant system, is to return blood to the heart. Arteries obviously deliver blood to the peripheral circulation. Arterioles, a very small volume of blood in the arterioles, but heavily involved in autoregulation at a local organ level and overall blood pressure control. And then the central blood volume will increase significantly from 15% to 25% when you're supine. Imogen, what is the Wind-Kessel effect? Someone referred to it earlier today, but what is it?
It's to do with the compliance of the vessels. So the way I think about it, when you have ejection from blood from the left ventricle, you get sort of a pulse in the artery, and it stretches, and the stretch stores elastic energy in the vessel wall itself, which can then be used to kind of contract again, which increases the pressure during diastole. So I guess that's the main function of it, is to increase the diastolic pressure.
Excellent. Yeah. No, I like your explanation there. And as you said, the main impact of that Wind-Kessel effect is that instead of having completely intermittent flow, where we only would have flow in systole with no flow in diastole, instead it's a pulsatile yet continuous flow. Good. No, I really liked your definition there. All right, it's 3-minute short answer question time, and away you go. So autoregulation is the ability of a tissue to regulate its own blood supply so that it receives the blood flow that it requires for its functions. It is intrinsic to each organ, and it's separate from any nervous system influence or hormone influence. Autoregulation can be either pressure autoregulation or metabolic autoregulation. The pressure autoregulation works to achieve a relatively constant blood flow despite alterations in systemic arterial pressure. And a good example of that is cerebral blood flow, where we see roughly similar blood flow between a mean arterial pressure of anywhere between 50 to 150 millimeters of mercury. And the mechanism by which that occurs is that when there's an increase in perfusion pressure, that causes an increased radius of the vessel, an increase in wall tension according to Laplace, which opens up calcium channels and results in vasoconstriction. There's also the metabolic influence on autoregulation, whereby the blood flow is altered according to the metabolic requirements of the tissue. That is particularly important in the brain, the heart and skeletal muscle. And in response to an increased rate of metabolism or decrease in available oxygen, there's a release of vasoactive substances, which results in an alteration in blood flow. And some of the mediators I've listed there, including nitric oxide, adenosine, potassium and histamine. And in terms of the organs that you could use as examples for autoregulation, we see autoregulation in the heart. We see cerebral autoregulation, and we see renal autoregulation. And together, those three organs receive quite a significant amount of the total cardiac output. Maggie, you're sitting August, aren't you? Why don't you have a go at this? What's a Starling resistor?
So the example would be in the lungs, where you have arterial pressure, alveolar pressure, and venous pressure, and the flow through the vessel can depend on the alveolar pressure, if that's the greater of the two.
Good. Yeah, I like that. So usually perfusion pressure is the difference between arterial pressure and venous pressure. But if there is an outside pressure on capillaries that's greater than venous pressure, then that will determine the gradient for flow. So for example, in the heart, the pressures that we would consider are arterial coronary pressure, coronary sinus pressure, which is the venous pressure, and intraventricular pressure. So in the left ventricle during systole, then the intraventricular pressure is higher than venous pressure, and therefore will impact on blood flow. Anyone else got some other examples of Starling resistors?
Cerebral blood flow with ICP and CVP.
Yep. The uterus during contractions would be another one, uterine blood flow. Good, okay. Another 3-minute short answer question. I want you to briefly describe the coronary artery anatomy. I'd like you to draw what happens to flow in both the left and the right coronary arteries throughout the cardiac cycle, and then describe coronary venous return. And what I've just put there is a little reminder that if ever you're asked an exam question about blood supply, then that always means arterial supply and venous drainage. So I've put in the separate question about venous drainage just to sort of drum that into us a bit. So I shall press go now, and I'll give you 3 minutes to do that. So the left main coronary artery divides into the left anterior descending with its diagonal branches, and the left circumflex with its obtuse, this here is the obtuse marginal branch of the left circumflex. Imogen, what do we mean by a dominant coronary circulation?
That means the left coronary supplies the PDA.
Excellent, very good. Yeah. So and most people have a right dominant. So as in this diagram here, the dominance of the circulation is which artery does the posterior descending artery arise from. 85% have a right dominant, and the PDA supplies the inferior wall of the left ventricle, and therefore there will be an impact on the pacemaker cells from that as well. Good. Then you would have gone on and drawn the phasic blood flow in the left and right coronary arteries. And as we said, because of the Starling resistor in early systole in the left ventricle, in fact, we will get flow reversal in the left coronary artery with most flow in diastole. And because of the lower pressures in the right ventricle, the difference in flow between systole and diastole will be less. And then you would have gone on and talked to me about coronary venous drainage. Most venous blood comes from the left ventricle, that drains into the coronary sinus, which empties into the right atrium. Blood from the right ventricle enters the anterior cardiac veins, which also empty into the right atrium. A very small amount of venous blood flows back via Thebesian veins into all heart chambers. And if we look at the blood in the coronary sinus, which is something that the cardiac surgeons cannulate for the retrograde cardioplegia cannula, it is extraordinarily dark. It's almost black. And that is because it has I think the lowest PO2 of just about anywhere in the body, because the myocardial oxygen extraction is very, very high at 60%, whereas overall average oxygen extraction is much lower at 25%. If we suddenly start exercising, how does our coronary blood flow increase? Pat, do you want to have a go at answering that for us? We got any thoughts on that one?
I guess in exercise, we increase our oxygen demand of our cardiac myocytes. And just from my notes that I've got here, it just increases adenosine release from your myocardial cells, which triggers a vasodilatory response as a result of the increased oxygen demand.
Yep. And what is that called? That, given that we've just sort of talked about that.
So an auto-regulation mechanism.
Yeah. Which type are you referring to then when you're talking about adenosine?
So that'd be a metabolic.
Good. Excellent. So coronary blood flow can increase 4 or 5-fold with exercise. And that's partly that you get an increase in aortic pressure and thus a direct increase in coronary blood flow. Even though the direct impact of sympathetic activation is vasoconstriction, the indirect influence that results in an increase in heart rate and an increase in contractility will increase oxygen demand, and therefore we get an increase in coronary blood flow. And as Pat said, metabolic autoregulations at play here in response to that increase in oxygen demand, and a number of mediators, particularly adenosine and nitric oxide, result in local vasodilation. What factors affect the myocardial oxygen supply demand relationship? Kristen, are you happy to have a go at giving us the factors that you've listed that affect myocardial oxygen supply?
Yes, good morning. Essentially, the first thing that comes to mind is obviously things that influence the coronary arterial vessels, which lends itself to the Hagen-Purcell equation. So flow versus resistance, and then sort of breaking the components of that down, that being viscosity and obviously things we can't change, length of the vessels and diameter. And I guess other things like hemoglobin are the main ones that I can think of.
Okay. What about coming back to the last little activity that you did, where you drew the coronary blood flow throughout the phases of the cardiac cycle?
Yes, heart rate.
How will heart rate affect your myocardial oxygen supply?
So with increased heart rate, we lose our time ratio for diastole phase of the cycle, which affects filling, in particular, that of the left side.
Good. So, yeah, I think we've covered most of those factors. The one in common, or the main one in common, is our heart rate. So if there's one thing that we can alter fairly acutely, intraoperatively, in the setting of myocardial ischemia, that is slowing heart rate down. And if we slow heart rate, we both reduce myocardial oxygen demand and we increase the time in diastole and improve our myocardial oxygen supply. So a tachycardia or a sympathetic stimulation resulting in a tachycardia in a patient with precarious myocardial oxygen balance because of disease states, because of coronary atheroma, is a double whammy. It both increases demand and decreases supply. I'm going to give you 3 minutes to discuss the factors that affect cerebral blood flow. Cerebral blood flow, it's not a bad idea if the question lends itself to start with a an equation in order to be able to hang the different factors on. So we could consider that cerebral blood flow is equal to cerebral perfusion pressure divided by cerebrovascular resistance, where cerebral perfusion pressure is equal to, and as we said before, a good example of a Starling resistor, mean arterial pressure minus the larger of intracranial pressure or central venous pressure. Factors that will affect cerebral vascular resistance include, as we said, metabolic autoregulation, and there's a linear relationship between cerebral metabolic activity and cerebral blood flow that will meet moment to moment both regional and global needs. And the figure that I've got is that there's a reduction of 7% of the cerebellum metabolic rate of oxygenation for each 1% fall in body temperature, and that results in a proportional reduction in cerebral blood flow. Next, we can consider the impact of pressure autoregulation on cerebral blood flow. And we said that there is a maintenance of fairly constant cerebral blood flow despite changes in the mean arterial pressure and obviously resulting cerebral perfusion pressure within that range of roughly 50 to 150. And then there is the impact that we need to consider on cerebral blood flow of both carbon dioxide and PO2. So the impact of carbon dioxide is again quite linear, with a 4% increase in cerebral blood flow for each millimetre of mercury change in CO2 over the sort of the physiological range. That's a linear relationship. Whereas, you know, the effect of oxygen is that the cerebral blood flow is fairly constant until we get to an arterial PO2 of around about 50, at which time there's a very significant increase in cerebral blood flow, and at about 30 millimetres of mercury, the cerebral blood flow is doubled. Not sure if I've got, yeah. And it would also be worth mentioning the Cushing reflex, which is that CNS ischemic response. If you get an increase in CSF pressure and brain compression resulting in a significant reduction in blood supply, the Cushing reflex is that maximal last-ditch sympathetic stimulation in an attempt to restore cerebral blood flow and oxygenation by increasing the mean arterial pressure. So what's the effect of posture on blood pressure? The impact of posture on blood pressure, I would consider that a three-part response. I would say we should discuss, first of all, what happens when you stand up, as in what happens immediately, how does the body compensate to that, and what would result in an impaired response. So in terms of what happens when we stand up, we get a pooling of blood in the lower limbs in the order of sort of half a litre or so of blood, and that results in a reduced venous return. There's also the hydrostatic effect of the fact that the head is now a good 30 centimetres above the heart, and that will result in a reduction in cerebral perfusion pressure. Equally though, that is offset slightly by the fact that there's a reduction in central venous pressure or cerebral venous pressure, and that helps slightly offset that, that hydrostatic effect in terms of maintaining cerebral perfusion pressure. But the overall effect is a immediate 20% reduction in CPP. How does the body compensate to that? Well, it compensates immediately with the arterial baroreceptor response that we just spent a bit of time talking about in some detail. Also, the lower limb muscle contraction limits the amount of blood pooling, and an equally important but not quite as rapid response to the arterial baroreceptor response is the impact of cerebral autoregulation. What causes that response to be impaired? Well, either if you have an inherent impaired baroreceptor response, if it's a hot day and you're vasodilated, then you're less able to venoconstrict. If you stand still, then we don't have the benefit of the muscle pumps improving venous return. And if you're in a state of low blood volume, then the reduction in venous return will be even more marked. Dom, if the mean arterial pressure at your heart level when you're standing is 90 millimeters of mercury, what would be the mean arterial pressure at the level of your brain?
Might be a 20 millimeter of mercury difference. So maybe your mean arterial pressure might be 70 millimeters of mercury. And how would you figure that out? If you're basing it upon a fluid column, I think you could measure the distance between your brain roughly and your heart, and then use the principles of a fluid column and estimation of your blood volume.
So if we measured the distance between the brain and the heart, and I told you that that was 30 centimetres, how would you convert that to pressure difference?
It's like, I think that 1 centimetre is like 0.8 or something.
So that's the factor by which you would alter. So 1,033 divide 760 in order to convert your 30 centimetres to what ends up being 22 millimetres of mercury. Okay, we've already done what impairs the usual response. Okay, let's have a look at this multiple choice question. Siak, would you like to have a go at that question for us?
I think it's D. Sorry, going through A. So the in phase 1 decrease in ITP, well, you have an increase in your intrathoracic pressure, so I don't think it's correct. In B, in phase 2, the increase in ITP results in a squeeze. So that's describing, I think, what happens in phase 1. And C, in phase 3, the sustained increase in ITP. Well, again, I think in phase 3, it's actually where it's the start of expiration, so you have a decrease in ITP. I think that's right. Yep.
That was excellent and a great explanation. Any questions on that one? So the correct answer there is D. It's the only one that matches the correct definition to the correct phase with what actually happens in a VALSALVA. So to run through the VALSALVA, what is it? Well, it's a sustained expiratory effort against a closed glottis or against a sealed mouth and nose, and the essential feature is the increase in intrathoracic pressure. Exactly as Siak's just told us, in phase 1 there's an increase in intrathoracic pressure that squeezes the intrapulmonary vessels. That results in an increase in venous return and an increase in stroke volume. The increase in intrathoracic pressure is also directly transmitted to the aorta and impacts on that slight increase in blood pressure. In phase 2, the sustained increase in intrathoracic pressure results in a decrease in right ventricular venous return that is sensed by baroreceptors, which limits the drop in blood pressure. In phase 3, there's a decrease in cardiac output because there's a loss of that squeeze on the intrathoracic pressure. And in phase 4, the normal venous return comes into the vasoconstricted vascular bed because of the aforementioned sympathetic activation, and that results in an overshoot in blood pressure, which is sensed by the baroreceptors and corrected by an increase in parasympathetic activity. Tom, what can you learn from observing someone do a VALSALVA manoeuvre?
VALSALVA manoeuvre can be a test of autonomic function. In people with autonomic dysfunction, you get a square wave response, where you get a failure of kind of baroreceptor compensation. It can also be, you can also learn about intrathoracic pressure. So in patients with things like cardiac tamponade, I have to think about this. You get, I guess any state where you get a decrease in venous return, whether there's hypovolemia or things like tamponade, you get a profound hypotension in response to the VALSALVA, I think. Well, it exacerbates the effect.
Yep, I agree with that. It would exacerbate the already impaired venous return by impairing it further. Can you say another, perhaps less acute disease state where the impact on venous return exacerbates that particular disease state, and therefore can be used to clinically differentiate between a couple of similar disease states? It's a little bit of a guesswork.
Did you say in acute states or chronic states?
If it's a chronic state.
Well, no, I can think of an acute state, which is SVT, where the increase in vagal tone stimulated by the VALSALVA maneuver can correct it.
Yep. But a state whereby a VALSALVA, in fact, is diagnostic in terms of separating this one particular condition.
Is this, it's a bit of a guess, but is it HOCM?
Yeah.
So if you have a dynamic cardiac output obstruction, it's made a lot worse by VALSALVA as opposed to a fixed obstruction.
Yeah, really well done. So it's the only murmur really that will increase, murmur that will increase with the VALSALVA is HOCM. Good, Tom. So as Tom said, it can be used as a test of autonomic function. To look at the VALSALVA ratio, you can either look at the longest RR interval on an ECG in phase 4 and compare that to the shortest RR interval in phase 2, or conversely, look at the heart rate in phase 2 compared to the heart rate in phase 4. Normally, that should be greater than 1.5, and if that's less than 1.5, that's a marker of autonomic dysfunction. A square wave response will be seen in a patient with cardiac failure, whereby you've got extra pulmonary blood volume, which acts as a bit of a reservoir. So phase 2 essentially acts like a prolonged phase 1. Because you never get that drop in blood pressure, you don't get the baroreceptor response. So you won't get the dip and the overshoot in phase 4. And as Tom said, VALSALVAs can also be used to both revert SVTs and diagnose HOCM. I'd like you to jot down your the 10 points that you can't miss for the cardiovascular effects at the onset of exercise, with a particular focus on the impact on myocardial oxygen supply and demand. In terms of the cardiovascular effects at the onset of exercise, we will have an increase in cardiac output, which is due to an increased venous return, an increased contractility, and an increase in heart rate. The increased venous return is facilitated by an overall decrease in systemic vascular resistance and the muscle pump, thoracic pump, that all improves venous return back to the heart. There's a slight increase in mean arterial pressure, but the effect on the blood pressure is small. There will be an increase in pulse pressure. We see a redistribution of blood away from the splanchnic circulation, the kidney, the skin, primarily to the myocardium and skeletal muscle. And I think it was Alex that told us that skeletal muscle at rest, we only have about 20% of the cardiac output going to skeletal muscle. That can increase to up to 80 to 90% with exercise. There shouldn't be a change in cerebral blood flow. There is an increase in oxygen extraction. and a very slight decrease in blood volume that will continue as exercise continues if hydration particularly isn't attended to. In terms of the question on what happens to the myocardial oxygen demand, that can increase up to 4 to 5-fold. And remember that our oxygen extraction is already fairly maximal at about 60%, which is why we said coronary sinus blood is extraordinarily dark with a very low PO2. So that increase in myocardial oxygen demand has to be met by an increase in coronary blood flow. If we were to ask what the effect of training is on that, those alterations with exercise, well, training improves our ability to deliver oxygen to active muscle, and that will allow an increase in your maximal cardiac output and a significant increase in your stroke volume. The athlete's heart is usually slightly hypertrophied and is able to cope with a much bigger volume. So a significant increase in stroke volume is possible. And there's also an increased ability of muscle to use oxygen. And that comes about by an increase in capillary density, an increased number of mitochondria, and increased enzyme activity, resulting in overall greater oxygen extraction. Back to you guys for another MCQ. I shall give you 30 seconds to have a look at this. Annie, would you like to have a go at this one?
So A, cardiovascular effect of PEEP is an impairment in RA filling due to increased intrathoracic pressure. I think to some extent it's true. B, the cardiovascular effect of PEEP is identical to phase 1 of a VALSALVA maneuver. I think B is true. In a patient with raised LVEDV, PEEP will improve the cardiac output by decreasing transmural pressure. Yes, so I think C is false. That's I'm pretty confident about. Patient with poor pulmonary compliance, the effect of PEEP on the cardiovascular system will be amplified. I'm not sure, so I'm going to say.
Okay, so you've ruled out C. I agree with you in ruling out C because the reduction in filling pressure, in fact, is favourable for left ventricular output in someone with a raised left ventricular end diastolic volume, and that's why something like CPAP is useful for a patient in acute pulmonary edema. Let's just address D. In a patient who has poor pulmonary compliance, then the raised intrapulmonary pressures with PEEP are not going to be transmitted to the great vessels of the chest. Therefore, the effect is going to be minimal rather than amplified.
Okay. Louise, can I clarify with this PEEP? So I read somewhere, or people think about doing sort of like a kind of like VALSALVA, but there's like the early phase of applying PEEP and then the late phase of PEEP. So the early phase, you squeeze out the pulmonary vascular volume into your LA that actually improves sort of like the preload, and then later phase you actually, because of the increased pressure, you obstruct flow, so then it decreases. What do you think of that kind of thinking?
What do you mean in terms of the early phase and the late phase, Annie?
I think they think about like a VALSALVA one. Say if you have a deep inspiration, you first sort of squeezes the blood, say from like SVC into the RA, so your preload actually, or the venous return improves. But then if you hold your breath, and that actually the increased pressure obstructs further venous return, and that decreases.
I think, look, that is absolutely true for a VALSALVA. I think the classic thinking with PEEP is that because it is applied really, it is applied to the patient all the time, although obviously the main impact is during expiration. My understanding is that it is more relevant to that phase 2 of the VALSALVA, where you've got that sustained, constant, always there increase in intrathoracic pressure. Admittedly, it's a small amount, normally in the order of about 5 centimetres of water. But that sustained increase in intrathoracic pressure can be an impediment to right atrial filling, and can result in a mild reduction in cardiac output. Although the two situations that were the other two options in the MCQ is that if you've got poor pulmonary compliance, the effects are going to be fairly minimal. But in a patient who has got an increased left ventricular end diastolic volume, then in fact the decreased filling pressure is favourable for transmural pressure, favourable for left ventricular output, favourable in terms of afterload that the left ventricle needs to eject against, and that is the reason why CPAP and PEEP in fact are useful in patients with pulmonary edema. Speaking of which, intermittent positive pressure ventilation is essentially the same as a VALSALVA, in that if initially, the initial inspiration results in an increase in intrathoracic pressure, increased return to the left atrium, resulting in an initial increase in stroke volume. Although the continued later portion of inspiration with a sustained increase in intrathoracic pressure will result in a decrease in venous return, and that effect will be amplified if you've got large tidal volumes. Again, during the early portion of expiration, initially the fall in venous return results because you've removed that direct compression on the pulmonary vessels, and then later in expiration, the venous return returns to normal. So the last SAQ, could you outline the cardiovascular effects of acute hemorrhage? So cardiovascular effects of acute hemorrhage. We need to cast our mind back to last week when we were talking about the mean systemic filling pressure. So that there will be a sudden and acute fall in the mean systemic filling pressure, resulting in a decreased venous return, decreased cardiac output, decreased blood pressure. And once we get to approximately 20% reduction in blood volume, we will see a significant drop in mean arterial pressure and cardiac output. How does the body compensate that? Well, there's an immediate arterial baroreceptor response and a low pressure baroreceptor response, resulting in increased contractility, increased heart rate, venoconstriction, and mobilization of any blood reservoirs in the body. Slower responses will result in an increase in ADH released from the posterior pituitary, angiotensin and aldosterone release, thirst and resorption of fluids from the tissue back into the intravascular compartment. There'll also be a CNS ischemic response if shock is advanced. And then over a period of up to sort of 72 hours, there'll be a gradual return to normal plasma volume, increased synthesis of plasma proteins, increased EPO levels, and increased new blood cell production. To relate the hemorrhage back to the changes in the vascular and cardiac function curves, initially the vascular function curve will move down, parallel but down to the original curve with a reduction in the mean systemic filling pressure. And in this example, say we've gone from 4 to 7. Venoconstriction will improve that somewhat. So you'll get an initial move from this first curve down to the more to the lowest curve that's marked A there, And then there will be somewhat improvement back to a midpoint as we get venoconstriction. And the cardiac function curve will be affected by the increase in sympathetic activity, moving that cardiac function curve shifted to the left. So the new equilibrium point, instead of being at this initial point here, will be to the left with the restoration of cardiac output. To finish, I thought we'd just do 4 little quick quizzes. You're going to do these individually. Each quiz has 3 questions, and we will correct each quiz before we move on to the next one. But I would like at the end of all of this, if you'd like to share it with us, your combined score out of 12. So I'll tell you how to mark each quiz as we go. And I will give you, I'll give you 2 minutes for each quiz. Okay, so quiz 1, your 2 minutes starts now. Okay, stop writing. So you'll notice that some of these we've covered in the last few weeks, but others will just be little things that I have noticed that candidates often just need a bit of revision over, and that just comes from sort of asking the short answer questions over the years. So the bolus dose for intralipid is a 1.5 mils per kilogram, not milligrams. Often people inadvertently write milligrams. So give yourself half a mark if you got the bolus dose right, 1.5 mils per kilogram. And then the infusion is 0.25 mils per kilogram per minute. Give yourself half a mark if you got the infusion correct. Fixed equation is either an all or nothing mark, and that is cardiac output is equal to VO2 divided by the oxygen content of arterial blood, that is CAO2, minus the oxygen content of mixed venous blood, C little v with the little line on it, O2. So if you haven't got the little line or you haven't indicated that it's mixed venous blood and you don't have that equation spot on, then you don't get a mark for the Fick equation. And the correct answer to question 3 is C. So pulmonary vascular resistance is increased with an increase in airway pressures. So jot down your mark out of 3 and get ready for quiz 2. Quiz 2, your 2 minutes starts now. So question 1, the main reason why end-tidal CO2 is generally, but not always, lower than arterial CO2 is dead space. The reason I ask this question is that I ask a short answer question along these lines, and I guess there's a number of related short answer questions. And generally speaking, if ever you've got shunt and dead space as 2 options, it says that you're not really clear on the concept. Generally speaking, if we're talking about CO2, a discrepancy in CO2, then we're talking about dead space. And generally speaking, if we're talking about oxygen, then we're talking about shunt. So if I was to ask the question, discuss and describe the reasons why end-tidal CO2 is lower than PaCO2, and your first answer is dead space and your second answer is shunt, it tells me that you're not 100% clear on the concept. Question 2, as was alluded to just a short while ago, the ability to convert between different measures of pressure, particularly at 1 atmosphere, is important. So 760 millimeters of mercury is 1,033 centimeters of water. So unless you had exactly 1,033, you don't get a mark. Optimal coefficients for damping. Again, damping is one of those concepts that does seem to cause a little bit of confusion. Optimal damping is 0.64, and I'll accept anywhere in the 0.6 to 0.7. So some people think of it as 0.67, whatever. So 0.64, but if you're in the range of 0.6 to 0.7, you can give yourself a third of a mark. Critical damping, sorry, not camping, critical damping is 1, and over damping is greater than 1. So both B and C, you have to be accurate in order to get your third of a mark. Okay, your 2 minutes for quiz 3 starts now. So the first one, money for jam, if you get a question on the arterial supply to the spinal cord, but easy to get confused between these concepts. So there is one anterior spinal artery. It arises from the vertebral arteries and it supplies the anterior 2/3 of the spinal cord. Now, the question 2, I think it would be very beneficial if you can commit those numbers to memory for calculating the alveolar gas equation, both say for room air and following pre-oxygenation. All I've asked you to do here is to write out the alveolar gas equation and then calculate the number of mils of oxygen in the FRC at room air. So what you would have written is P big A O2 is equal to the FiO2 multiplied by 760 minus 47, close brackets, minus P little a CO2 divided by 0.8. That is equal to, at room air, 0.21 multiplied by 760 minus 47, close brackets, minus 40 divided by 0.8. That is equal to 150 minus 50, which equals 100 millimetres of mercury. Next, you need to go on and show what percentage that is of the gas in the alveolus, and then multiply that fraction by the number of mils in the FRC. So then you would go on and say 100 divided by 760 as a fraction, multiplied by your FRC, which is 30 mils per kilo, give or take. That fraction or that percentage of 100 over 760 is 13%. Multiply that by the 2100 mils for an average 70 kilogram patient, and that would give you 273 mils of oxygen. The reason I think you need to know that is both for short answers and vivas, if you're asked to basically explain how pre-oxygenation works or how quickly a patient will desaturate when they're rendered apneic, you can explain that using the alveolar gas equation. And you can see that for room air, 270 mils is going to be gone in a minute, or perhaps even more if someone has a higher oxygen consumption than the typical 250 mils per minute. But you could also then go on and solve the alveolar gas equation again for 100% oxygen or for 90% oxygen, and could show that you can increase that number of mils of oxygen up to, I think up to maximum is about 600 and something mils of oxygen. In terms of marking for that, I think you can just use your discretion. If you got it all exactly right, as I've said, you can give yourself a mark. If you got the first bit right and you got up to 100 millimetres of mercury, but you didn't, you weren't able to then translate that to a number of mils of oxygen, just give yourself half a mark. And question 3 would have been easy since we've gone through that today, and the correct answer to that is B. All right, last quiz, last 2 minutes. So the correct answer to question 1 is A. Coronary arteries do come directly off the aorta. It is the right brachiocephalic that splits into the carotid and the subclavian. The right carotid and the right subclavian, with the left subclavian being another direct branch of the aorta. 1 atmosphere pressure is equal to 101.325 kilopascals. If you got 101, you can have half a mark, otherwise no marks. And if you've got 101.3, you can have a full mark. And the right ventricle pulmonary artery pressure time curve. And so you should have had the right ventricle pressure that starts at 0 and goes up to 25, with the pulmonary artery that has a diastolic pressure of about 8, again up to the maximum of 25. If you've got the opening and closing of the tricuspid and the pulmonary valves, you can give yourself a full mark. If you've got the rest of the diagram without the with the correct pressures but without the valves, you can have half a mark. All right, guys, well, thanks very much, and I look forward to seeing some of you around in the coming months.